We'll move on to the next discussion with Dr. Paice, who is a professor at Northwestern University. She's going to talk to us about pain management and palliative care, building on the most recent presentation.
Yes, thank you so much for sticking with us this afternoon. And Megan just gave an outstanding presentation that very nicely dovetails with the kind of information I want to share with you today. So I'm going to start with talking with you about pain management, and then we're going to move into the issues of palliative care and some of the things that might be helpful to you as you're learning to live as a cancer survivor or a person with cancer. We're going to define some of this. Now, they call me the pain and the poop nurse up on the oncology clinic because so many of the medicines that we use, unfortunately, contribute to constipation. So one of the things you might be really surprised to learn related to pain is that even with the most sophisticated scanning devices that we now have available to us, we still can't always tell by looking at you if you have pain. I could look at all of you sitting in the room and I can't see, there's no big giant arrow pointing to any of you. So what that tells us is you need to share with us the way you're feeling. Yes, we can do PET scans and CTs and functional MRIs and all sorts of sophisticated diagnostic testing. And then, of course, we can look at underlying etiology, but that doesn't always translate into how you feel. So please do tell us, don't assume that we know. So there are multiple causes of pain in the person with cancer, from the tumor itself, but also the diagnostic testing. Yes, we cause pain sometimes as much as we try our best not to. And some of the treatments, as you just heard, can lead to syndromes like painful peripheral neuropathy or persistent post-surgical syndromes. People who have the type of cancer where they're treated with hormonal therapies can sometimes get aches and pains related to the hormone treatment. So various causes can lead to pain in people who have cancer. It's really important as you're going to be meeting with your healthcare professional to think about the way the pain feels. Again, we can't know whether you have pain or not, nor can we know what does it feel like. And even though this seems really simplistic, this is key to developing our understanding of the etiology, but also to the treatment plan. So, is the pain nociceptive? This is one of our terms for pain that's really more musculoskeletal in origin, aching, throbbing kind of pain. It's usually pretty well localized too. If any of you have not been to the gym for a while and you get back into that treadmill or that exercise cycle, and the next day you're feeling some warning signs there that those muscles have been reactivated, that's a typical kind of nociceptive pain. And I would again just like to emphasize, when Megan was talking about fatigue and how one needs to exercise, otherwise you get deconditioned and that leads to more pain, I would also add, it leads to more fatigue, I would also add it leads to more pain. Because as you get more deconditioned, you start to develop joint pain and muscle pain. So exercise is not only helpful for fatigue, it also helps prevent some of this musculoskeletal pain. We have visceral pain. Visceral pain's a little bit more challenging and less well understood in that it can be diffuse. Can't always point to the precise location. It's often associated with sensations such as squeezing and cramping. And then Megan already shared with us one example of neuropathic pain, the peripheral neuropathy that we see usually with oxaliplatin or with paclitaxel, but can occur from people who might have uncontrolled diabetes, for example. So these different kinds of pain syndromes lead your professional to think about different treatments. So again, really do contemplate what that pain feels like and share some of those sensations. All of this is important information to us as we develop a plan together. Now, when we talk about the goals of care for pain relief, we really, in the best of all possible worlds, would like to prevent it. And the surgeons are developing superb expertise in using preventive strategies before they even make their first incision to prevent some of the post-operative syndromes that we see. But we don't always have the option to prevent pain, and then we're left with relieving it, and we've got a myriad of treatment options available. And clearly we need to improve function because that improves your quality of life. If we just leave you with pretty decent pain control, but you're just lying in bed, much like that video that Megan showed us earlier, that doesn't improve your outlook and your interaction with the world. And of course, we need to do all of this in a safe environment, in a safe strategy. So what are some of these techniques that we have available? Well, of course, we have medications, and I suspect everyone who's been treated for any type of cancer has at least been exposed to some of these medicines. The easy ones are the non-opioids, drugs like acetaminophen or the non-steroidal anti-inflammatory drugs. And honestly, for brief periods of times, these drugs are okay, very beneficial. And in fact, most are available over the counter. But for longer periods of time, they actually have significant adverse effects that we do worry about in the face of gastrectomy, in the face of having had persistent chemotherapy and how that might affect the kidneys and the liver. So do let your doctors and nurses know whether you're taking these medicines, even if you didn't get a prescription for them. They do have their own set of adverse effects that we worry about. The opioids are agents that would be prescribed by your healthcare professional, and these can be very powerful and appropriate agents that can be used to relieve a variety of pain syndromes. And then we use adjuvant analgesics. This is our third category of drugs. These actually include agents like anti-seizure medicines, antidepressant drugs, the local anesthetic agents, and even corticosteroids. Most of these were developed for other purposes, but along the way we learned that they can be very, very helpful for nerve pain. So that neuropathy that Megan talked about, or some of the post-surgical syndromes where people have sensitivity over the surgical incision area, even after it heals. And then, of course, we don't want to forget that anti-cancer therapies can be profoundly beneficial in reducing the tumor burden and thereby reducing pain. Sometimes we call in our anesthesia colleagues or the interventional radiology colleagues or gastroenterology folks who can then do interventional techniques, different kinds of nerve blocks. Celiac plexus block is one that we use for significant pain syndromes. Some of you may have heard of like epidural steroid injections. Those are great when people have different kinds of spinal issues or other kinds of joint concerns. We use integrative therapies, and we've already heard interest in things like acupuncture. And although it's challenging to conduct those really rigorous clinical trials, the randomized controlled clinical trials, because it's complex to develop a sham procedure, but there's a long history of acupuncture, and many people do obtain benefit, and frankly, there's limited risk. Massage for some kinds of pain, particularly musculoskeletal kinds of pain, can be of benefit. And honestly, the biggest risk for both acupuncture and massage is the little bit of risk to the pocketbook, because unfortunately, many of our insurance companies haven't identified the efficacy of these therapies, and they're still not paying for them. But then physical measures, PT, OT, exercise, again, you're probably thinking that Megan and I conspired ahead of time, but honestly, we just met for the first time, even though we work in the same institution. But these can be the most advantageous kinds of techniques, not only to relieve pain, but to keep up your posture, to help with reducing fatigue. It really improves sadness and depression, helps our outlook on the world. And then cognitive behavioral therapies, reframing, guided imagery, relaxation, all of these techniques can be amazing, not only for pain, but also when we have the sleep problems. You know, many of us can fall asleep at night, but then you wake up in the middle of the night, either to void or with pain, and what happens? your brain kind of turns on and you think about all those what ifs and you can't turn it off. Well, there are wonderful apps with relaxation techniques, meditation techniques, short, easy ones to do. You don't have to become a yogi to do these. These are really beneficial. So be your own advocate, as I talked about earlier. Don't assume that we understand. And these are some of the questions that you really kind of contemplate and maybe even write them down before your appointment. Where is the pain? What does it feel like? How intense is the pain? Now, we tend to use that 0 to 10, and I know everybody kind of gets disgusted with it because in the hospital, the nurses are asking this, it seems like every 15 minutes, but we really do look at the trends, how it changes. What are you currently taking? Bring all your pill bottles to your session so we know, and include those over-the-counter medicines. It's really important. What have you tried in the past? What worked, what didn't? That also helps so we don't have to reinvent the wheel. And have you ever had a bad reaction to pain medicines? Really beneficial so that, again, we don't use something that didn't work well for you. And let us know that you're having pain. You might want to even keep a diary for a short period of time. It helps us to know how many pills do you need to obtain good control. We might be able to find other formulations of the medicine so you don't have to take the pill every 3 hours. It also helps us to know if there's a particular timing in the day when you have more pain. Again, we might be able to devise a treatment plan that addresses that. Don't store your pills in the bathroom medicine cabinet or on the kitchen counter. You've probably heard, if you watch the news, we have a bit of a problem with drug diversion going on. We want your medicines to be safe. The first place someone with bad intent who's going to look at is in your medicine counter. Ask any real estate agent in the city of Chicago. They know when they hold an open house, they advise clients to get all the medicines out because a couple will come in, one will distract the real estate agent, the other one will make a beeline for the medicine cabinet. Unfortunately, you will be targeted if people know, and it could be a cleaning lady, it could be a repair person. If someone has addiction, unfortunately, they are going to steal your medicines. And when you're done with your medicines, dispose of them safely. Again, here in the city of Chicago, we're really lucky. The police stations have a take-back program. No questions asked. They take them back and they incinerate them. So they're not going into our water supply, which is really important as some neighborhoods are struggling with antidepressants, hormone therapies, and other medications being seen in the water supply. So that's a very quick introduction to pain management, and we can address more specific questions during the question and answer period. I want to address some misconceptions about palliative care, because I know it's as scary as the pain word, and there's so much misunderstanding. Palliative care is not hospice. Palliative care is not for the dying. Palliative care is for the living. So what is palliative care? Here's the formal definition. It's an approach that improves the quality of life of patients and their families. Yes, it addresses the families too. We want to help people who have a life-threatening illness from the moment that they've been diagnosed, and if we could even help people earlier through prevention, but we also want to prevent and relieve any source of suffering, whether that's fatigue, as Megan talked about earlier, or whether it's nausea and vomiting, or whether it's pain, whether it's emotional distress at having a diagnosis. And so we address physical problems, psychosocial issues, and spiritual concerns. And they're part of your team. This allows your oncologists to devote all of their time to the treatment of the cancer. You have a nutritionist that helps address issues related to food intake and nutritional intake. You have a nurse, a physician's assistant, a nurse practitioner to help address concerns. Social workers, medical assistants, these folks are just part of the team. And studies looking at palliative care have demonstrated that people who have early integration of palliative care with their cancer treatment have improved quality of life, and here's what's even more provocative. They have longer survivals. So amazing benefits. So again, as I mentioned with pain, you gotta tell us, what are the symptoms that you're experiencing so that we can address them? Don't assume that we know. It might be pain, it might be anxiety. Megan shared with us how many cancer survivors experience anxiety. And especially after treatment, there's some sort of comfort that comes in with being in the clinic frequently, and all of a sudden, when you're no longer needing to be in the clinic and seeing us regularly, sometimes there's a little anxiety associated with that. Oh, I'm not getting treatment anymore. Am I being watched as closely? What if something happens? Constipation, again, pain and poop nurse, I'm always asking folks. It's my second favorite question. What about loss of appetite, sadness, sleep problems, communication? So we ask folks, some people want to know everything. I suspect that being that you're spending your Saturday here, you are those kind of folks. But we also acknowledge that some folks don't want that, and we have to respect their wishes. And so we need to know your preferences and your wishes. Don't hesitate to tell us your wishes and your family's wishes and your family's needs. So I want to share with you some information about living with cancer and taking care of yourself. Megan already set a beautiful foundation. I want to share a few more things. So exercise. Again, we didn't really conspire together. It strengthens muscles. It improves your balance. It maintains your mobility, reduces fatigue. It improves your memory. So those of you who are feeling like you've got a little chemo brain, or frankly, those of us with a little few gray hairs, that memory just doesn't seem to be what it used to be, exercise is a great treatment or preventive agent. It improves appetite, it boosts your mood, and it decreases your stress. Focus on what you can control, because there's times when it feels like life is just out of your hands and you just don't have the control that you used to. Express your feelings. That's tremendously important. Especially those things that make you feel overwhelmed. When you get them off your chest, it actually frees your energy. It allows you to feel more control. And yeah, some of the things that you might be expressing maybe seem a little scary. Things like sadness or grief or denial or anger or stress. But also, there's joy and there's wonder and there's hope. There's a metaphor that I always like to share with folks. Do you remember Pandora's box? That old myth? Pandora was told, don't open this box, but she did anyway. And what flew out? All of these furies and evils and scary creatures. And it was a horrible experience. It was really frightening. But once all of those evil creatures came out of the box, do you remember what was at the bottom? Hope. So sometimes we have to let loose with some of those emotions before we can even hear about hope. And yes, Megan talked a little bit about power of attorney for healthcare, but there's other things you can do to help your family. So the things you can control, plan, organize your personal affairs. We actually should all be doing this on a regular basis. Important legal documents, insurance documents, those safety deposit boxes, pensions, retirement plans, have it all together, have it all organized. I tell my husband this all the time. Advanced care planning, as Megan talked about. Ensuring that your wishes are understood and honored. That's what this is all about. This is not about planning for death. This is about planning for life. And advanced directives were nicely described. And it's not giving up. So again, things you can control, look for the meaning in your life and celebrate your life with loved ones. That's what this is all about. So here's some ways you can celebrate your life. Maybe some of you have already thought about this. Make a video. Put together family albums. Develop a family history so you can leave this for your great-great-great-grandkids. A family tree is a way to learn where you came from, and again, leaving more information for your future generations, keeping a journal, recording a funny or meaningful story. And again, for those of you who are here from Chicago, we have a great opportunity. If you've ever been to the Chicago Cultural Center, there's a box there, a recording studio for StoryCorps. If you listen to NPR, you've heard the StoryCorps stories. No cost. You go there with a loved one or a friend, and you spend 10, 15 minutes, and one person will interview the other. And that gets recorded, and it actually is stored in the Smithsonian. So what an amazing, and it might even be chosen to be aired on NPR. So what an amazing legacy. So write notes and letters to your loved ones. Create art. Give meaningful objects to your loved ones. Plant a tree. All sorts of amazing things. Leaving favorite recipes. That's my favorite one. I love it. An ethical will is something that has been discussed, and it's different than your typical will where you think about what you're going to leave to different people. In fact, instead of leaving objects, this is leaving a legacy of who you are. What do you value? What do you want your kids to know about you? What are the lessons you've learned? It's more about who you are and shared in a way that a lot of us are a little too shy to do so at the dinner table. And then what about those of you who are caregivers? Bless your heart for being here. I'm so glad to see so many wonderful caregivers. So you've all learned what not to say. You look awful. Everything happens for a reason. Maybe it happened for the best. I just want to punch someone when they say that, right? Everyone's dying. No one knows how long they'll live. You could be hit by a bus tomorrow, right? Are these helpful statements? Are these empathic statements? Not at all, but people don't know what to say, and they feel like they have to say something. So if a neighbor or a distant relative says something like this to you, swallow hard and just kind of take a deep breath and say, ah. And maybe at another point you can teach them what's really helpful. Here's what's really helpful. Tell me what's helpful and what's not. Tell me if you want to be alone and when you want company. You might even want to say something like, can I come over and help you do the laundry? Or can I help cook dinner for you tonight? That the person can always say no, but be specific. If you say something as obtuse as, let me know if you need anything, most people are reluctant to take you up on that offer. Tell me what you want me to bring and tell me when you want me to leave. People are tired. So for those of you who are caregivers, take care of yourself. So all that advice I just gave before, exercising, etc., that's for you too. Connect with others, laugh. You know what? There's something amazing about watching a silly old Marx Brothers movie or whatever it is that makes you laugh. That deep breathing is really good for the body and for the soul. So watch a good movie. I prefer Groucho. Communicate with loved ones. If you find that it's really complicated, you've got a big family or a huge network, there are websites that instead of having to call 20 people every night to give an update, you can just download information on that website. This happens to be one. It's called Caring Bridge, but there are many others. It just frees you up with your time. And here are a few other resources that I just wanted to leave with you. So the NCI produces these two wonderful monographs. These are free, so you can obtain them from the National Cancer Institute website. One is for the person with cancer, and one is for the person who loves that person. The American Cancer Society has amazing resources as well. Lots of support and treatment. The NCI's website, again, amazing resources for you. The Robert H. Lory Comprehensive Cancer Center website includes many resources for people with cancer. And again, for those of you who live in the city, I particularly wanted to highlight this page because it lists the area resource centers. There's a loosely connected network of centers. One is in Hinsdale, one is in Northbrook, one's in Homewood. These are places where you can go and get a massage. Some of them have Reiki, some of them have acupuncture, many have counseling, support groups, nutritional counseling, classes on cooking, sleepovers for the kids if their parents have cancer. Gilda's Club is in the city. These are amazing resources, and they are free. They run through philanthropy and donations. So really look into those if you're from Chicago. This is Life Matters Media, another website that's of enormous benefit for folks with cancer. So again, thank you so very much, and I'll leave you with this quote. Thanks again for inviting me today.
Dr. Paice, that just fantastic presentation. If there are any questions in the crowd, are there, and I'll read one off while we're waiting from the website, are there downloadable tip sheets to facilitate conversations with family? And do you recommend using third-party assistance for this?
So when there are conflicts within family, or when it's a struggle to talk with family about some of these really charged emotional issues, then there are Life Matters Media and other websites that I shared that do give some tips about how to do this. Those NCI monographs that I shared with you also include some helpful strategies about how to hold these conversations. It's not easy. Not every family is communicative about these kinds of issues. Some families are very open. My father told me about his wishes. I remember when I was a small kid, he was always very open about these things, but other family members, not so much. So you have to think about your family, what's acceptable, and use these guides to help.
Great. I have a question. You said your second favorite question was asking about pooping.
Yeah,
What's your
sorry.
first favorite question?
Pain, of course.
So along those lines for pain, one of the things that comes up a lot when even I try and prescribe pain medicine, patients or families of patients are concerned about addiction. Can you comment on that and how that plays in this setting?
So I touched on some of the ramifications in our society right now. You hear about it in the media. It seems like every news report has something about opioid-related overdose deaths, the diversion of these medicines, people selling these medicines. And the truth is, people who have pain, who take these medicines, who do not have the risk factors for addiction, do not develop addiction. OxyContin is the drug that's gotten the bad rap, so I'll use that as an example. Just because you give someone OxyContin does not mean that they are going to become an addict. The person who's at risk for addiction is someone who has a prior history of substance misuse, so a long history of excessive alcohol intake, possibly cigarette smoking. We're still unclear precisely about that as a risk factor. People who have used drugs of misuse for a long period of time. And then here's another bizarre and really sad risk factor that's a very strong predictor. People who have been sexually abused as preteens or teenagers have a very high risk of addiction. So it is not the drug that makes the person an addict, it's their genetics, it's their environment, it's the factors around that individual. Now, what does that mean? Does that mean that people with risk don't warrant pain medicine? Of course they do. It just means we need to use some special procedures, some special care as we're prescribing pain medicines. But for those of you that don't have those risk factors, you do not have to be concerned about the potential for addiction.
You mentioned OxyContin, and so my question is, can you give a little bit of detail about what it is to have a short-acting versus a long-acting pain medicine, and how you direct patients how to use those and when and why?
Sure. So I know sometimes we're asking you to become doctors, nurses, physician's assistants, pharmacists, and all of the healthcare professions rolled into one. So there's two basic kinds of opioids. And opioids is the word I use for narcotics, because narcotics is a word that is actually not accurate. Narcotics is a legal term, right? That's what you see on NCI or one of those TV programs, right? So opioids is the family of drugs like morphine, oxycodone. You've heard of Dilaudid. And we have short-acting and long-acting. For those people who have just kind of sporadic pain that's only there for a short period of time each day, they can be well managed with a short-acting opioid. It peaks in about an hour. So if you know you're going to do something that predictably causes pain, some people, for example, with bone metastasis tell me that, if they're going to be standing up, trying to get in the car in that twisting location, getting to the clinic, it's always painful, then take the medicine about 45 minutes before you're going to get in the car so that it's working at its maximum. Now, some people have pain more often. It's kind of persistent throughout the day and night. They would benefit from something long-acting. And the long-acting agents either have a special coating on them that allow them to be gradually absorbed through the stomach or the intestines into the bloodstream, gradually over a 12-hour period or a 12-hour period, or there are patches that are changed every 3 days and the drug is absorbed through the skin. So the long-acting opioids are of benefit when people have persistent pain. And some people need both, by the way. The long-acting hits most of their pain, but they'll have spikes or breakthrough.
Very helpful.
Thanks.
Another question here. When exercising for pain management, when do you know, or when does the patient know that they might be overdoing it?
So for someone who's not been exercising for a long time, and Megan, you can help contribute to this too. If you haven't been exercising for a long time, don't expect that you're going to get back to where you were in one session. So that's the biggest mistake I see folks making. Like, I'm never going to be running a Chicago Marathon. I'm going to hurt really badly if I just bounce into that, right? So work it up gradually until you feel some muscle pain or some discomfort, and then stop. Give it a break. And then the next day or next 2 days, then go just a little bit further, tiny bit, and then work it up gradually. And if you really might benefit, some people find working with a physical therapist or even an exercise physiologist or a personal trainer. Anything I've missed there?
Like I said before, the go slow, start low, go slow, that is the best way to do it when getting back into an exercise regimen after being inactive for a certain period of time.
Great. Another question I had when I saw you put a slide up that said, organize your affairs and telling patients about this. And we heard a little bit earlier that maybe sometimes patients aren't ready yet, patients and families aren't ready yet to hear that and maybe have a negative experience of being told that. So my question is, and even someone that also has to struggle with telling that information, and when is the best time to do that? When a patient's first diagnosed, or is it after a few visits? What is the strategy you think might be best to kind of get this information out, but in a softer manner, so to speak?
Yeah. So the truth is we all should be doing this, and there are some communities now that are having everybody. There's a town in Wisconsin where everybody has done this advanced care planning kind of work. And honestly, it's important for all of us to do this, to be able to say, here are my wishes, here are my values. If something happened where I couldn't speak for myself, I got a really bad infection and I couldn't communicate my wishes, I'd want somebody that I designated to be able to say, Judy would have wanted this. Judy wouldn't have wanted that. And I know some people think it means giving up. But instead, I think it's hope for the best, right? Let's hope that we're going to have wonderful, productive, lengthy lives. But if we plan for the worst, it's all off the table and taken care of, we can do that hoping and living. I know that might sound a little bit simplistic, and I'm not going to lie to you. I know it evokes emotions. It makes us think about the value of our lives, and yet it is so very crucial.
Great. And it's something along those lines. You also had a slide where palliative care versus hospice, and they're not the same. Can you give us a few words about hospice, when you think it's appropriate, et cetera, so that we understand what it is, et cetera, and the differences to palliative care?
So hospice was developed as a Medicaid, Medicare benefit, and it is very prescribed in who can be enrolled in hospice. And the general rule of thumb is if an individual has a predicted lifespan of 6 months or less, they would benefit from and be able to participate in hospice. Hospice is a wonderful therapy. It treats the patient and their family. And for most people, when people know they have a life-threatening illness and that their prognosis is short, when you survey most Americans, they say they'd really like to be in their home when the end comes. Unfortunately, without planning, where does the end really occur? Whereas 80% of people say they'd like to be in their home when they die, surrounded by the things that are comfortable and by their puppy and by the comforter and the family members around them. Unfortunately, in our society, because we don't plan, 80% of people die in an institution. So the people who care for you in hospice are especially prepared and trained to address complex symptoms, to help your family, so it really is family-focused care. And another part of the benefit of hospice is that when that person dies, hospice remains a part of the family, providing bereavement and grief support for another year later. So there's prolonged benefits of hospice, both for the patient and for their family members.
Wonderful. Okay, any other final thoughts or questions on this session?
Yes, ma'am.
Yes.
For pain.
Great.
So that is a superb question. I grew up in the 70s, unlike our former president. Yeah, so you can take it from there. So we are in Illinois right now, and Illinois passed the Compassionate Cannabis Act, but it's not quite yet available to patients. I do have many people obtaining medical marijuana or cannabis, the Phyto Cannabinoids. Some people find relief for anxiety, for sleep issues. The data about pain control with the Phyto Cannabinoids, in other words, with the inhaled stuff, is pretty weak. There are a few studies for neuropathy and HIV, a few studies in people with cancer. They're small studies. My general rule of thumb, as a cancer nurse for 30 plus years, I never thought I would have encouraged someone to inhale if they're thinking about it. But I will mention that when you look at some of the adverse events that are occurring, like in Colorado, where it's recreational, it seems to be associated when people eat it. And that's partly because the bioavailability, in other words, how the THC and the cannabidiol, the active ingredients, how they get into the bloodstream is very delayed when you swallow it. But when you smoke it, it's very quick. So what's happening is someone takes a brownie or a piece of chocolate or a pot tart as is being sold, and they eat it and they don't feel anything, so they eat another. And then they eat another. And because of the long delay, people are ending up in the emergency room with frank psychosis. So even though I do worry about the effect of the particulates in the lung, many people can smoke, obtain some benefit with just 1 or 2 inhalations. And there are people working on safer ways to inhale the cannabinoids without getting so much of the particulates in the lung. It's a very complicated topic and obviously one fraught with a lot of controversy, but that would be my quick and dirty answer to you.
The other thing to be careful with is if you're going to make a movie, like was suggested, and you mix with the marijuana, you've got to be careful with what exactly you're videotaping. Okay.
I have a quick question. I didn't hear you guys discuss at all the Pca pumps, and do you guys use them, and what are their benefits?
So Pca pumps are primarily used in the hospital in most patients because generally it's parenteral, it's IV. In some rare cases, we use it sub-Q in the tissue, but mostly it's used IV. And we really would prefer for people who are at home not to use that kind of technology. We hate to have IVs accessed. There's always the risk for infection, et cetera. But in the postoperative period, there have been numerous studies that demonstrate that when people have control, they actually feel better overall in terms of their pain relief. It's usually morphine or Dilaudid that's being administered. There are some times when a few folks need to have it long term, but that's not common. Yes?
This question is also, it's actually a comment about the PCA. My mom has been on a PCA for the past few months because her stomach cancer was primarily, she had stomach cancer, was her primary with mets to the peritoneal cavity, and now she has it in her esophagus. So one of the problems she's having is she has a hard time swallowing, and she spends a lot of time throwing up.
Yes.
So I feel like from a caregiver point of view or an advocate, I feel like it would be beneficial to the patient if it's something that we told them that is actually available to them, because she has a PCA, she has it at home. I had to advocate and fight for it, but she did take it home. She wears it every day, and she's, at the very least, it's managing her pain. And I think that when we know that our patients are, have terminal cancer, and that this is not going to be something where they're going to be addicted, we want to know that they're at the very least comfortable. So I feel, she went home with TPN, something that, again, I know it has a high risk of infection, but when you're dying, I think that we have to kind of advocate for the patient in the sense of where are the pros and where are the cons. And I think having the PCA and the TPN available for her at home and not having to say she wants to be hospice, which she doesn't want to be, for as long as she can, I think that I wish more patients and more caregivers knew that advocating for it, it's a possibility to actually take it home and not have to have your loved one suffer and try to take pills every day, 20 pills a day, when they're throwing up all day long.
So your mom's very fortunate to have you.
Yeah.
You're a great advocate. Thank you for sharing that. Thanks.